my name is Disa. Welcome back to my veterinary series. So today we're going to be talking about TPLO surgery, also known as tibial plateau leveling osteotomy. This kind of surgery is for a very specific injury. So in human medicine, we know this kind of surgery as ACL surgery. In veterinary medicine, we call this a CCL tear. So we call this a cranial cruciate ligament because the way that the dog is situated, that would be cranial instead of anterior. In order to understand the surgery, let's discuss a little bit of the knee anatomy. The cranial cruciate ligament that is located here, this ligament is responsible for stabilizing the knee joint and connects your femur to your tibia. This ligament prevents anterior sliding of the tibia on the femur and limits hyperextension on the knee. An injury to this ligament can cause the femur to slide against the back of the tibia, causing pain, inflammation, and a lot of discomfort. And that's why quite often one of the indicators is that your dog will be non-weight bearing on that leg. So often they will toe touch after some sort of, a walk, some exercise or something like that. They will start lifting their leg off the ground. This technically sits in an articular capsule is what they call it. So this surrounds a synovial joint. It encloses the synovial cavity and it houses the articulating bones. So this whole area means articulating bones, and it also unites the articulating bones. When we talk about a synovial joint, we're talking about a joint that is able to move freely. That is just sort of the term that we use for it. So then of course we have the patella, which is also the kneecap. This would be the femur here, and this would be the tibia, and this is the fibula, which is the smaller bone, sort of on the more lateral aspect of the leg. Behind the cranial cruciate ligament, we have the caudal cruciate ligament. So in human medicine, the cranial cruciate ligament is the anterior cruciate ligament, and the caudal cruciate ligament is the posterior cruciate ligament. This ligament here, it prevents the posterior sliding of the tibia on the femur. We also have the lateral collateral ligament here. In human medicine, this is known as the fibular collateral ligament. This strengthens the lateral aspect of the joint. And the last thing I want to mention in here is the menisci. Menisci plural, meniscus singular. This one's the lateral meniscus, and this one is the medial meniscus. The menisci helps to compensate for the irregular shapes of the articulating bones and circulate synovial fluid. A TPLO surgery completely changes the dynamics of the knee, so a working ligament doesn't even matter anymore. But how does this work? So as a surgical assistant, I must take radiographs of the stifle of interest. We do two views, a lateral view and a DV view, or a dorsal ventral view. The radiographs are then used to get the tibial plateau angle and reduce this angle. So we include what is called a MAG marker, so the surgeon can make the measurements based off of this, which sits flush with the tibia and femur, the condyles where they meet. When it comes to surgery, we might start off with a stifle arthroscopy. This is a minimally invasive technique that is used to examine the joint, examine the meniscus, make sure there's no tear, and if there is a tear, we can easily get rid of the medial meniscus. We like to get rid of the medial meniscus because sometimes a tear in there is also causing the clinical signs that we're seeing. So in short, once we have the site of interest and everything's looking good, we will then take what is called a TPLO saw and make a semicircular cut. A TPLO saw has a sort of half circle shape. We don't want anything too big and we don't want anything too small. We want just the right size. Once we found the right size, we'll make a semicircular cut, and then from there we will use an osteotome and a mallet in order to mark our points where we're going to align them to find the proper rotation. Once everything is aligned the way we want it to be, we'll drive a pin in, and this will secure the two bones together so the surgeon no longer has to manually rotate it themselves. Once we've done that, we will find the right size plate, and then from here it is my job to switch over the drill bits. So we drill a hole into the bone using a drill and a drill guide. We'll drill a hole into the bone. From there, we will use a depth gauge to measure the depth of the hole, and then it is my job to switch over the end bits of the drill and then get the right screw, measure the screw to make sure it is true to size, and then insert that screw into the hole so the surgeon can drill it in and secure the screw. The surgeon will flex and extend the knee to make sure that it is in fact the right angle that we've got, everything looks good, and we can close. As you can see here on the left side, that's the lateral view. You can see the pin and the plate placed on there. And then on the right hand side here, you can see the, this is the DV view, so it shows the screws, and it shows that none of the screws are protruding into the stifle joint. So that is it for my talk today about TPLO surgery. Next week I will be talking about PDA surgery, also known as patent ductus arteriosus surgery.